Hello students, welcome to Module 3, Introduction to Fetal Heart Rate Tracing and Fetal Well-Being Assessment. Before we start, I just wanted to let you know that this is an introduction course to fetal heart rate tracing. As you know, in healthcare, we have certifications in cardiac life support, so CPR certification, and then we also have a basic life support certification. And for those nurses or physicians who work in higher acuity units, such as your ICU, ED, L&D, there's also advanced life cardiac support, ACLS. So very similar to the actual labor and delivery world. As a nurse working in labor and delivery, there are extra certification that you do have to obtain. First, you must get your beginner's fetal tracing certification, and then there is an intermediate fetal heart rate tracing certification, as well as an advanced electronic fetal monitoring certification through A1 and so forth. So today you will get an introduction to fetal heart rate tracing, but we will be talking about this during class, as well as in this lecture, as well as during the first week of clinical orientation and then subsequent weeks to come. So this will not be the first time, but it will be a lot of material. So at any time during this slide, as we're explaining, if it's difficult to understand, please pause and just kind of review what was discussed and review the slides, so that way you have a better understanding of the actual concepts when it comes to fetal monitoring. So with that being said, let's get started. So in order to search for fetal heart tones, you will see abbreviation FHTs, fetal heart tones. There's multiple ways for us to be able to get fetal heart tones. Number one, that can be done by ultrasound. 2, by an actual Doppler. 3, external fetal monitors. And 4, internal fetal monitors. And we're going to discuss that in the next few slides. But before we get that, obtain the fetal heart rate tones, it's very important for us to actually do the Leopold's maneuver. Leopold's maneuver is obviously named after Dr. Leopold in 1894. These are 4 actual maneuvers where we actually feel for fetal presentation so that we're able to diagnose the location of the fetus in utero. Upon diagnosing the presentation, it helps guide us as to where to look for the actual fetal heart tones. So as you can see here in the picture, A, B, C, and D, you want to start at the top of the fundus, and then the second maneuver is the side by side of the actual quadrant of the actual uterus, and then the bottom part, which is above the pubic symphysis, is where you can actually palpate the baby's head potentially if the baby is there. And then of course the last maneuver is the lower uterine segment, and you're palpating basically for the actual back. If you feel something that's actually flat and straight, that's the best part as to where to locate the actual fetal heart tone, and that's where you will put your ultrasound or your Doppler fetal monitors and so forth. So I love this picture of the above, as you can see from the external, but in the bottom segment of the pictures, you can actually kind of see the actual structure of the actual fetus. So that way you know where the presentation is and where to put that transducer. So as we talked about, there is a difference between an ultrasound and a Doppler. Normally, we don't always use an ultrasound, especially in the outpatient setting, in the prenatal setting. They normally do this for your formal ultrasound, and if there's any complications with the pregnancy or any complications with the fetus, and they need better visualization of the fetus, the structures of the heart, or if there's concerns about growth, restriction, and things like that, an ultrasound is the best way to actually see what's going on with the baby. And obviously you have your Doppler, very similar to the Dopplers that we use for, DVTs and so forth, and blood flow. So very similar, but this one's to actually capture the fetal heart tone. The more famous one, you guys will have an opportunity to help assist in placing external electronic fetal monitors. The external monitors include two components. One is the TOCO. TOCO for touch. So you're going to put the TOCO on the top of the fundus, and this connects to the actual electronic fetal monitor. Once you connect that, you'll have to zero it out basically using the UA reference. And the TOCO itself measures the contraction, duration, and frequency. It does not measure the strength of the contraction because it is external, and external monitors are not precise. The sono, which is the bottom portion, think about sono for sound, sound of the heart, fetal heart rate. And so after doing your Leopold's maneuver and you've determined the best location to actually place the sono is where you actually add you'll also notice on the sono that there's a little bit of a dish, and on that dish is actually where you actually put the gel, and this helps in the conduction process to be able to pick up that sound wave for the actual fetal heart rate. So again, TOCO for touch, so that's for your fundus, the top of the fundus, and then sono for the sound of the baby's heart rate. That will be usually at the bottom. So let's just say you have a sono that's up high. What do you think? What position do you think that baby is in? All right, good job. That's going to be a breech baby, right? So the head's not down. The head is actually at the top of the fundus facing north. So the baby basically is that the chest and the back will be on the upper segment of the uterus. So the sono might be placed on top if we're doing fetal tracing prior to a C-section or something like that. So please make sure you know the difference between a TOCO and a sono. There will be occasions where we need internal monitors, but before we actually place an internal monitor, we have to make sure that the patient's membranes, the amniotic sac, is ruptured, because in order to actually monitor the internal strength of the contractions or any of the fetal heart rate tracing, we have to make sure that the membranes are ruptured. So the first device is called an IUPC. It is an intrauterine pressure catheter, and this is where we actually accurately measure the strength of the maternal contractions using the mercury per milliliter, where we actually measure it in Montevideo units. You don't have to know or calculate Montevideo units, but you do have to know that we do monitor contractions and we count the strength of the contractions and so forth. There is another device called FSE, fetal scalp electrode. This is an actual electrode that is placed on the fetal scalp. It is connected to the external monitor, of course, but it's a non-traumatic way to actually measure more accurately what the fetal heart rate tracing is and so forth. There are a couple contraindications for internal monitors. So obviously if a mom is HIV positive or hepatitis B positive, if we have face presentation or breech presentation, we do not place any of these items. However, again, every situation is a little bit different. It's going to be case by case, but for the most part, these are the contraindications for internal monitoring. And on our clinical day, for your clinical skills and simulation day, you will actually see these devices in person. You'll be able to see and touch and feel and so forth. All right, so when it comes to fetal tracing, we use a piece of paper uh, to measure the actual record the actual tracing. In labor and delivery, depending on where you work, some nurses actually record the tracing on a piece of paper, and then in most places, majority of facilities now have central fetal surveillance, where the fetal monitoring system is displayed in the room, on the units, on the walls. It's pretty much everywhere. And so, as we're talking about the actual measurements, it applies both on paper as well as on the actual computer screens or TV screens. So, as you can see here, if you're looking at this graph on the right-hand side, the upper right side, um, you see the 10 seconds. That little tiny box is 10 seconds in measurements. So one box equals 10 seconds. And if you have 6 of those boxes, that would equal 60 seconds, also known as 1 minute, which is on the right-hand side there. You have 6 10-minute segments, which equals 1 minute. And if you're looking at the bottom, that is to record the actual uterine activity or the uterine contractions, and that's scaled in the millimeters per mercury. This is how we actually trace fetal heart rate tracing and contraction tracing. It's transferred to either a piece of paper or a computerized platform. All right, so let's focus on fetal heart rate. There are 4 steps when measuring fetal heart rate. It's important to make sure that we follow the step-by-step guide. Normal fetal heart rate is 110 to 160, 110 beats per minute to 160 beats per minute. The newborn fetus in utero does have a higher heart rate than normal adults. So again, please make sure you guys know what is normal for fetal heart rate. First and foremost, you want to establish the baseline. So just like adults, we all have different baselines. Same with the fetus. Usually if they are in early in their gestation, fetal gestation, usually they're more tachycardic. As they become term, they start to normalize between 110s, and again, everybody has a different baseline. Every baby has a different baseline. So first and foremost, you want to be able to establish your baseline. And the second step is to measure variability. So variability is the fluctuation in the fetal heart rate baseline. Again, this is done in minutes, as well as we're capturing the amplitude of the frequency. So basically, it's your beat-to-beat push and pull balance between the sympathetic and parasympathetic system. So it's basically your beat-to-beat heart rate for that actual fetal heart rate. Accelerations is a third step. You need to determine if there is any positive or negative accelerations. Acceleration is an increase of the fetal heart rate from the baseline to at least 15 beats above the baseline for at least 15 seconds long. And this is for babies that are 32 weeks gestation or above. If you are less than 32 weeks, the fetal heart rate acceleration is categorized by 10 beats high for at least 10 seconds long, so 10 by 10. So again, 32 weeks and above is a 15 by 15, and if it's less than 32 weeks, it's a 10 by 10. And the last step is the deceleration. So once you've established your baseline, your variability, if there's acceleration, the last step is to determine if there's any deceleration. And a deceleration is a decrease from the baseline, indicating a complication ranging from normal to bad regarding that fetal well-being. So we will go deep into the deceleration segment in a little bit. There are good decelerations, and then there are also bad decelerations, so depending on the situation. Again, these terminology that you see in front of you is very, very important. Please make sure you understand what a baseline is, what is the variability, what is an acceleration, and what is the deceleration as you're measuring fetal heart rate tracing. All right, so let's kind of break this down. So again, normal baseline for fetal heart rate is 110 beats per minute to 160 beats per minute. Anything below 110 is considered bradycardic. So anything below 110 is considered bradycardia. And anything over 160 beats per minute is considered tachycardia. So again, normal baseline is normal heart rate is 110 to 160. Bradycardia is anything less than 110, and tachycardia is anything greater than 160. Please make sure you know what's normal and what's not, what's abnormal. All right, so here's an example of a fetal tracing. As you can see, the top segment is the fetal heart rate tracing. The bottom segment is the actual contraction. And if I were to draw one straight line through this fetal heart rate tracing, I can establish my baseline. So my baseline would be 150 beats per minute. And when it comes to variability, I see moderate variability. We're going to go into that in a little bit here. So far this baby's looking really healthy to me. There's fetal well-being, which means that the central nervous system is intact. The baby's sympathetic parasympathetic system is working. The baby's oxygenated. There's no compromise to the neurological status of this fetus. The bottom segment is your actual the uterine contraction tracing. So again, please make sure you know what the frequency, definition of a frequency, duration, and how to actually calculate that and so forth. So this is a great example of a tracing. Example number 2, here's another tracing where you see these little dips, these little V-W-shaped dips. These are called decelerations, and we're going to go into that later also. There are different types of decelerations, but again, make sure you follow your steps when it comes to actually documenting your fetal heart rate tracing. And then here's another fetal tracing example. As you can see, this heart rate baseline is about 100 beats per minute. All right, so let's focus on fetal heart rate. There are 4 steps when measuring fetal heart rate. It's important to make sure that we follow the step-by-step guide. Normal fetal heart rate is 110 to 160, 110 beats per minute to 160 beats per minute. The newborn fetus in utero does have a higher heart rate than normal adults. So again, please make sure you guys know what is normal for fetal heart rate. First and foremost, you want to establish the baseline. So just like adults, we all have different baselines. Same with the fetus. Usually if they are in early in their gestation, fetal gestation, usually they're more tachycardic. As they become term, they start to normalize between 110s, and again, everybody has a different baseline. Every baby has a different baseline. So first and foremost, you want to be able to establish your baseline. And the second step is to measure variability. So variability is the fluctuation in the fetal heart rate baseline. Again, this is done in minutes, as well as we're capturing the amplitude of the frequency. So basically, it's your beat-to-beat push and pull balance between the sympathetic and parasympathetic system. So it's basically your beat-to-beat heart rate for that actual fetal heart rate. Accelerations is a third step. You need to determine if there is any positive or negative accelerations. Acceleration is an increase of the fetal heart rate from the baseline to at least 15 beats above the baseline for at least 15 seconds long. And this is for babies that are 32 weeks gestation or above. If you are less than 32 weeks, the fetal heart rate acceleration is categorized by 10 beats per 10 beats high for at least 10 seconds long, so 10 by 10. So again, 32 weeks and above is a 15 by 15, and if it's less than 32 weeks, it's a 10 by 10. And the last step is the deceleration. So once you've established your baseline, your variability, if there's acceleration, the last step is to determine if there's any deceleration. And a deceleration is a decrease from the baseline, indicating a complication ranging from normal to bad regarding that fetal well-being. So we will go deep into the deceleration segment in a little bit. There are good decelerations, and then there are also bad decelerations, so depending on the situation. Again, these terminology that you see in front of you is very, very important. Please make sure you understand what a baseline is, what is the variability, what is an acceleration, and what is the deceleration as you're measuring fetal heart rate tracing. All right, so let's talk about variability again. So variability indicates fetal well-being and oxygenation status. So when we talk about variability, there are 5 types of variability. There's absent, minimal, moderate, marked, and sinusoidal. And for test-taking purposes, it's important to know these different types of variability. And we'll go into detail also about the fluctuation in the heartbeats and so forth. So absent variability is 0 beats of variation from baseline. So basically, if I was to draw one straight line, it is straight as can be. There's no fluctuation in the heart rate. If my baseline is 150, it's 150 for the next 10, 20 minutes, okay? And this is not good. This is really, really bad. This means that there's some compromise or insult to that fetus in utero. There are some oxygenation issues going on. Something's happening to this baby where there's no beat-to-beat variation. So if you think about adults when they have asystole, there's no heart rate. For babies, it's a little bit different. They're not quite there yet. However, they do have a negative, they have a 0 beats in their variability, which means it's absent. Minimal is 1 to 5 beats of variation from baseline. This is too low. Sometimes there's reasons why this occurs. So if a baby is sleeping, if the mom received IV pain medication and she received narcotics, she's a little drowsy, a little groggy, it may cause her to kind of be a little bit, sleepy. That does affect fetal heart rate as well, because everything that mom gets through the IV obviously is passed through the placenta, through the umbilical cord, through the actual, the veins and vein, and so that baby is actually, getting a little bit of that medication. So you may see minimal variability. However, there are times when that's appropriate, as long as you know what the reason, what the cause is, and how to intervene appropriately to make sure that it doesn't stay permanent. The next thing is the moderate variability. This is normal. This is what we want to see. As you can see, the color green. This is good. This is 6 to 25 beats of variation from the baseline. So if I have a baseline of 150, I'm beating up to 156, or I could be beating down to 140, 144, and so forth. Just that fluctuation from beat to beat that varies from the actual baseline. So this tells me that my baby is oxygenated, it's healthy, I should have no concern about this baby. Marked variability is when there's greater than 25 beats per minute above or below the actual baseline, and this is very, very bad. Usually this is a compensatory mechanism where the baby is basically compensating for the distress of whatever situation it's going through. You might see this towards the end of labor as mom's pushing. It causes that baby to kind of bagel a little bit, beat extra fast, and it's like this big jiggity jaggedy line where we call it marked. This is again greater than 25 beats per minute above or below the baseline. And then sinusoidal is a little bit different. It's more of like a sawtooth kind of pattern, absent variability type. This actually indicates that there's something going on in utero, indicating fetal anemia. And of course, this is very, very bad. So we're anticipating some type of bad outcome. We definitely want to make sure that the NICU team is present for the delivery. This baby may actually require a transfusion down the road. So again, please make sure you know the terminology and the definition and what is good and what is bad. And we're going to talk about this a little bit more. I know this seems like a lot, but again, we will definitely be spending more time on that. So here's an example of the different types of variability. So the first one, as you can see, the fetal heart rate tracing, it's absent. There's no detected heartbeats above or below, right? The actual baseline. So it's almost like a straight line across the board. Number 2 is the minimal variability, which is your less than 5 beats per minute. So there's a little bit of fluctuation between beats to beat, above the baseline or below the baseline. Number 3 is the moderate variability. This is actually what we want to see. This is really, really good. Usually it's between 6 to 25 beats per minute. There's that beat to beat variation. This is a very, very healthy baby that's oxygenated. There is no compromise with oxygenation. Central nervous system is intact. This is a baby that's doing really, really well. Number 4, this is an example of marked variability. As you can see, you gotta have like some high peaks and some low peaks. It's like this extreme fluctuation in the actual beat to beat, which is normal than greater than 25 beats per minute. And then the number 5 is an example of a sinusoidal pattern. As you can see, it's very smooth. It's very there's a smooth pattern where there's a fluctuation, and it's almost like a sawtooth kind of pattern. This, again, is indicative of fetal anemia. And so if we do see something like this, we definitely want to notify the provider and make sure that the NICU team is there for the actual delivery. And here are some more examples of the different types of variability. There's marked variability, moderate variability, minimal variability, and absent variability. So again, please make sure you know and recognize what is good, what is bad, understanding the definition as well as the criteria for each of these different types of variability. All right, so let's focus on fetal heart rate. There are 4 steps when measuring fetal heart rate. It's important to make sure that we follow the step-by-step guide. Normal fetal heart rate is 110 to 160, 110 beats per minute to 160 beats per minute. The newborn fetus in utero does have a higher heart rate than normal adults. So again, please make sure you guys know what is normal for fetal heart rate. First and foremost, you want to establish the baseline. So just like adults, we all have different baselines. Same with the fetus. Usually if they are in early in their gestation, fetal gestation, usually they're more tachycardic. As they become term, they start to normalize between 110s, and again, everybody has a different baseline. Every baby has a different baseline. So first and foremost, you want to be able to establish your baseline. And the second step is to measure variability. So variability is the fluctuation in the fetal heart rate baseline. Again, this is done in minutes as well as we're capturing the amplitude of the frequency. So basically, it's your beat-to-beat push and pull balance between the sympathetic and parasympathetic system. So it's basically your beat-to-beat heart rate for that actual fetal heart rate. Accelerations is a third step. You need to determine if there's any positive or negative accelerations. Acceleration is an increase of the fetal heart rate from the baseline to at least 15 beats above the baseline for at least 15 seconds long. And this is for babies that are 32 weeks gestation or above. If you are less than 32 weeks, the fetal heart rate acceleration is categorized by 10 beats high for at least 10 seconds long, so 10 by 10. So again, 32 weeks and above is a 15 by 15, and if it's less than 32 weeks, it's a 10 by 10. And the last step is the deceleration. So once you've established your baseline, your variability, if there's acceleration, the last step is to determine if there's any deceleration. And a deceleration is a decrease from the baseline, indicating a complication ranging from normal to bad regarding that fetal well-being. So we will go deep into the deceleration segment in a little bit. There are good decelerations, and then there are also bad decelerations, so depending on the situation. Again, these terminology that you see in front of you is very, very important. Please make sure you understand what a baseline is, what is the variability, what is an acceleration, and what is the deceleration as you're measuring fetal heart rate tracing. All right, so once we've determined the baseline, we've determined the variability, the next step is to determine the acceleration. So we had talked about, for example, the baseline being 150. An acceleration is marked by an increase in the fetal heart rate above the baseline for at least 15 beats and last for at least 15 seconds long. And normally these are appropriate for 32 weeks and above fetus. For babies or fetus that are below 32 weeks, the criteria is the 10 beats per minute, lasting 10 seconds long. So as you can see in this picture here, it's a really good indication of what an acceleration is. You can see here the baseline, and of course there's no numbers because I don't know what number the baseline is. But as the baby's baseline, it starts to rise, which is the beginning of the acceleration, and it goes up, let's just say, I believe that is 110. So a baseline of 110 going all the way up to 160, and then going above 160 to about 170, and then it ends back down to the baseline. And if you actually measure this, if the baseline is 110 and it's going all the way to 170, that technically the acme, which is the top of the actual tracing, that meets its criteria of 15 beats per minute. So it's gone all the way up to 170. So that's a difference of 60 beats per minute, right? And then, of course, looking from beginning to end, that's greater than 15 seconds, obviously. It looks like it's about a minute and a half or so. So that acceleration there is what we call the perfect acceleration. This means that the baby is healthy. There's no concerns about oxygenation. We like to see a couple accelerations within a 20-minute time frame to indicate that the baby's doing well. So here again is another example of an acceleration. So if your fetal heart rate is at baseline is at 135, you can see that the baby does beat the beat to beat. There's fluctuation in the variability, and then it goes all the way up to about 155 and goes back down to baseline. So please make sure you take the time to really look at this and understand what you're looking at. The goal is to have at least 15 beats per minute for 15 seconds long for those that are 32 weeks and above. For a fetus that's less than 32 weeks, we definitely want it to meet the criteria of like 10 by 10. If you have any questions at all, please don't hesitate to reach out to us or the instructors. We are happy to assist you to help understand all of this. So again, if you're looking at a strip, this is an example of another strip. You can see I am looking at the strip. There's 3 accelerations, which is really, really good. This is excellent. That means that this baby is happy and healthy. Here's another example of a strip where there are accelerations. Again, this is indicative of fetal well-being. It's reassuring the baby is healthy. We are not concerned with this baby whatsoever. All right, so let's focus on fetal heart rate. There are 4 steps when measuring fetal heart rate. It's important to make sure that we follow the step-by-step guide. Normal fetal heart rate is 110 to 160, 110 beats per minute to 160 beats per minute. The newborn fetus in utero does have a higher heart rate than normal adults. So again, please make sure you guys know what is normal for fetal heart rate. First and foremost, you want to establish the baseline. So just like adults, we all have different baselines. Same with the fetus. Usually if they are in early in their gestation, fetal gestation, usually they're more tachycardic. As they become term, they start to normalize between 110s. And, again, everybody has a different baseline. Every baby has a different baseline. So first and foremost, you want to be able to establish your baseline. And the second step is to measure variability. So variability is the fluctuation in the fetal heart rate baseline. Again, this is done in minutes as well as we're capturing the amplitude of the frequency. So basically, it's your beat-to-beat push and pull balance between the sympathetic and parasympathetic system. So it's basically your beat-to-beat heart rate for that actual fetal heart rate. Accelerations is a third step. You need to determine if there's any positive or negative accelerations. Acceleration is an increase of the fetal heart rate from the baseline to at least 15 beats above the baseline for at least 15 seconds long. And this is for babies that are 32 weeks gestation or above. If you are less than 32 weeks, the fetal heart rate acceleration is categorized by 10 beats high for at least 10 seconds long, so 10 by 10. So again, 32 weeks and above is a 15 by 15, and if it's less than 32 weeks, it's a 10 by 10. And the last step is the deceleration. So once you've established your baseline, your variability, if there's acceleration, the last step is to determine if there's any deceleration. And a deceleration is a decrease from the baseline, indicating a complication ranging from normal to bad regarding that fetal well-being. So we will go deep into the deceleration segment in a little bit. There are good decelerations and then there are also bad decelerations, so depending on the situation. Again, these terminology that you see in front of you is very, very important. Please make sure you understand what a baseline is, what is the variability, what is an acceleration, and what is the deceleration as you're measuring fetal heart rate tracing. All right, so we talked about baseline, we talked about variability, we talked about accelerations. The last step is to actually determine decelerations. Decelerations are split up into 2 different types and categories. Some are harmless, and then some are also very severe, which means that the baby is in severe distress. So we have 4 types of decelerations. We have early deceleration, variable deceleration, late deceleration, and prolonged deceleration. Excuse me for a second. So let's talk about early decelerations. So early decelerations are good. These are the ones that actually mirror the contractions. These are as you can see, as the uterus is squeezing that baby, that head is being pushed down, and that compression on the head causes the dip in the fetal heart rate. So as the uterus is squeezing that baby, the peak of the contraction, the fetal heart rate tracing kind of dips and mirrors the actual contraction. This is good. There's nothing really, when you see a strip like this, except I just want you to focus on the actual deceleration part and don't look at the variability, because the variability is almost absent here. Anyhow, so we don't really do anything here. We just watch, we continue to watch that strip and make sure that the baby's not compromised, assist, in the labor process. This means that the patient's progressing, the baby's coming down. These are all good signs that labor is heading in the right direction. Variable decelerations, uh, these types of deceleration will come regardless of the contraction. So it can occur with the contractions, or it can actually occur without the contractions. It's very spontaneous also. So this indicates cord compression. So you'll see a sharp dip, abrupt drop in the fetal heart rate, and when you're recording this, it may look like a V, a W, or a U formation. So that's because the cord's being compressed. So that, sometimes we don't know exactly where the cord's at, or if the cord's wrapped around the baby's neck or the baby's body, or if the baby's actually holding the cord, you might actually have some variable deceleration. How do we fix this if you see something like this? We definitely have to do something. So that means that because the cord is being compressed, oxygen supply is being cut off abruptly to that fetal heart rate. And so we definitely need to do, step one is to do least invasive, which is change maternal position. You may have to turn her left to her left or her right, sometimes high Fowlers, sometimes knee to chest. Different positions may alleviate that pressure off that cord wherever it's being compressed. And then second step is that if it continues, if the patient water has broke and there's not enough fluid inside the actual amniotic sac to cushion the cord, we may actually have to do an amnio infusion, which is a procedure where we actually put fluid back into through the vagina using the IUPC and putting fluid back inside the amniotic sac. And we will definitely talk about that a little bit later in regards to the management of amnio infusion. But please recognize a variable deceleration. Again, it can be a V, it can be a U, it can be a W, it can be any sorts of shape with or without the contraction, and it's abrupt. A late deceleration are the most dangerous types of deceleration because this is indicative of a placental insufficiency. So the deceleration will begin at the peak of each contraction, and this does not mirror the contraction, but it looks like it's slightly behind the contraction. So as the uterus is squeezing and it's peaking, because the placenta has all of this blood flow, if there's an issue with the placenta, and as it's being the uterus is being squeezed, there's less blood flow going through the placenta, blood flow going to the umbilical cord. Hence, there is a delay in the actual drop in the fetal heart rate. So we will teach you a little bit how to care for patients when you see this type of tracing. We use the POISE acronym, POISE. In a little bit, we'll talk about how to take care of these types of patients if you see these types of strips. All right, so again, this is a mnemonic, nursing mnemonics picture. It really helps you understand what the pattern is, what is the cause, and how to manage it. So again, if you have variable decels, it's because of cord compression, and the management for that is just maternal repositioning. If you see early decels, that's related to head compression, which is good. We just identify the labor process, we continue to watch her, we don't do anything whatsoever. A is for acceleration, and that is okay. That's great. This means that the baby's oxygenated. We are not concerned about the fetal well-being. The baby's doing great. The baby's happy. The baby's healthy. We just continue to watch, so there's no interventions required. And then last, L for late deceleration, and that's caused by placental insufficiency. Or you may also hear uteral placental insufficiency. And then at this point, you would execute the POISE, P-O-I-S-E. Perfect. So fixing late deceleration. So POISE is an acronym. It doesn't really matter which order. Mainly for patients, again, if the patient is on Pitocin, we're using Pitocin as a titration medication to augment labor or to increase labor contractions. The first thing you want to do if that baby is having late deceleration is to turn off the Pitocin. Because the uterus is squeezing that baby, we want to make sure that during that process, we stop those contractions because the baby is already compromised. We don't want to cause too many contractions, which will eventually tire that baby out and impeding in the oxygenation of that baby. So P for Pitocin if the patient's on Pitocin. O is for oxygen. So we definitely want to make sure we give her some oxygen. So that way, if mom's getting, oxygenation, perfusion, hopefully all of that will go through the placenta to the baby. I is for IV bolus. Normally we do an IV open wide. S is for side lying. So again, alleviating the pressure off the inferior vena cava, superior vena cava, and the aorta. So we want to increase as much perfusion as we can through the placenta, through the umbilical cord, so that the baby can get a rush of like oxygenation and perfusion, right? So let's turn her on her side and help her in that process. And then E is for extra help. So this is an acronym that we use to help fix late deceleration. And you definitely have to know this for your exams. All right, so I want you guys to look at this strip. Tell me what you see. Again, let's go through the steps again. First and foremost, you want to establish the baseline, the variability, the acceleration, and then the deceleration. So let's determine what the baseline is. So here in the baseline is about 150 beats per minute. And then after you establish the baseline, you want to identify if that is an actual, what type of variability. So remember we talked about variability. There's absent variability, there's minimal variability, there is moderate, marked, and sinusoidal. So what type of variability do you see? Okay, so I see moderate variability. And then what kind of deceleration do you see here? Does the decelerations mirror the contractions, or does it, or do you see variable decelerations, or do you see late deceleration? And as you can see here at the tip, the baseline is about 155, and if you draw one straight line down, you can see that these are earlies. It mirrors the contractions, right? So this is a good thing. That means labor is progressing. And here are some variable decelerations. So you see your U's, your V's, your W's. There's an abrupt drop in the fetal heart rate. This can last for 10 seconds, 20 seconds, or even a minute on that last variable deceleration. You can see that decel is about 60 seconds long. So making sure you recognize what you see and how you will respond to the actual deceleration. All right, so here's the third strip. What type of deceleration do you see here? If you answered late decelerations, you are correct. So with late decelerations, we definitely want to implement the poise. P for Pitocin, O for oxygen, I for IV fluid, S for side lying, and E for help, extra help. And if you look at this strip, ooh, this is a really ugly strip. Um, First of all, there is no variability. So we establish the baseline, and then the variability is absent. So there's a straight line, there's no fluctuation in the fetal heart rate. And on top of that, we're having late decelerations. So this baby is very, very distressed. It's a very obvious sign of if we don't deliver this baby soon, we may have to code this baby when this baby is born. So if you ever have this type of strip, when it comes to the delivery portion, we definitely have to make sure we call the pediatrician, the NICU team, because we're anticipating a depressed baby at birth. They may have to intubate, give epinephrine, do chest compressions, and things like that. So we do not ever want to see these types of decelerations and strips. All right, so the next one is a prolonged deceleration. So as you can see, the heart rate drops. It's prolonged because it's longer than 2 minutes. And if I'm looking closely, the heart rate initially starts at 150, and then it dips down and stays down even past the contraction. So as you can see from beginning to end, we're talking about like a 3.5 minute decel here, and it's a prolonged decel. This too is treated with a poise, making sure that you figure out what the cause is and intervene appropriately. And if the fetal heart rate doesn't return back to baseline, we may have to notify the provider, and then other measures will have to follow. So this is another example of a prolonged decel. So a prolonged decel, as you can see here, on this particular strip, there was variable decels that actually led into a prolonged decel. And the cause was a uterine rupture, which means that the uterus actually ruptured. The muscle itself separated, causing an emergency C-section. This is a great example that I found on the internet where the nurse documented her time, the C-section time, as well as the pH levels and so forth. Kind of have a hard time reading her writing, but anyhow, this is an example of a deceleration, prolonged deceleration combined with a variable deceleration. We definitely do not want to play around with this. You're definitely going to call for help and make sure that we're ready to go to the OR for C-section delivery. So we talked about fetal tracing, which is the top segment of the actual tracing. The bottom section is your contractions. So again, make sure you understand the definition of frequency, duration, intensity, and then resting tone. So frequency, again, is measured from the beginning of one contraction to the next contraction. And this is usually measured in seconds and or minutes. As you can see here, it's a good example at the bottom there, the duration and the frequency. Duration is the actual, is basically measured how each contraction lasts. So usually at the start of one contraction to the end of that same contraction. So there's a difference between duration, frequency, and intensity. So this is measured by seconds, and that's the bottom segment of the actual tracing, those little mountains, little hills that you see there at the bottom. And again, when we do external fetal monitoring, it's very, very subjective, even though on tracing it looks like it may be a very big contraction. everything is a little bit subjective when it comes to the external monitoring. It's not accurate. It doesn't really measure intensity. So when we measure we palpate the actual uterus, we palpate the fundus. That's where we put our toco. And when we're palpating the contractions, we can actually categorize it as mild, moderate, or strong. So if you feel your nose, that's considered mild. If you tap on your chin, that's considered moderate. And if you feel your forehead, that's considered strong. When it comes to intensity, external monitoring, we don't usually document intensity. However, if we do have internal monitors using an IUPC, we are actually monitoring the actual intensity of the contractions inside the uterus. Then this helps us calculate our Montevideo units. Normally, adequate labor is about 200 MVUs. So if you look at this contraction, you don't have to learn, you're not required to actually calculate Montevideo units and MVUs, but please know that MVUs are more accurate because it is internal using millimeter mercury per measures. So this is just for you to know for the MVUs, but intensity is more accurate when we actually have internal monitors. All right, so hyper stimulation, uterine stimulation. There's two verbiage. You might hear uterine hyperstimulation, or the most recent is the tachysystole. So this is when it's defined as having 5 contractions or more in a 10-minute segment. So if you have those red boxes, if you have 10 of those red boxes, that's 1-minute segments. And if you have more than 5 contractions, then that's considered hyperstimulation and or tachysystole. So the goal is to have at least, less than 5 contraction. You're contracting every 1 to 2 minutes. There's rest in between. Normally, ideally, the resting tone should be at least, we want the uterus to go back down and rest for at least 60 seconds in between those contractions. And otherwise, we're definitely going to have problems down the road with uterine contractility. At some point, that muscle will get tired. So it's very important to make sure that we don't overstimulate the uterus, or especially if the patient's being titrated with Pitocin. All right, so this is just an example, a picture. Because the uterus is a muscle and the placenta is also being utilized during this process, all of that, when the baby's being squeezed, blood flow does change when it crosses the placenta, right? So as I said before, if you have too many contractions, that can actually reduce the blood flow to the actual fetus. So basically, at the peak of each contraction, there is no blood flow to the uterus. And if the contractions are occurring too frequently, that means that fetus will not actually have oxygen, and it's not able to go back and relax in between. So this can cause some issues down the road. All right, so a non-stress test is a type of procedure that we do on labor and delivery and or the high-risk clinic, NST clinic. So basically, this is where we measure fetal well-being. We want to know how that baby's doing, especially for our high-risk pregnancy patient. If that baby is compromised and then something's happening in utero, normally the non-stress test will tell us. So again, we're using an external monitor. We're using our toco and our sonos to monitor the baby. And an NST, a successful NST, a positive NST, a reassuring NST, has at least 2 accelerations in a 20-minute time frame. So remember we talked about accelerations. Those are the 15 by 15 or the 10 by 10. If a baby has acceleration, that means that the baby's fully oxygenated There's no issue or compromise to the central nervous system or the neurological system. So when we're doing a non-stress test, we want to see 2 accelerations within a 20-minute time frame. However, sometimes there might be a delay. The NST might go longer than 20 minutes, 30 minutes, as long as you actually have 2 acceleration within a 20 to 30 minute time frame. If the non-stress test is non-reassuring, that means that the baby, there's a compromise with the fetus somewhere, obviously in utero, and we don't know the cause. Maybe the cord's tied in a knot or around the body, or there might be a Doppler flow issue. There might be a little bit of IUGR. There's a lot of different reasons where you might have a non-reactive NST. So the goal is to have a reactive, a reassuring NST. That shows us that that baby is healthy and it's happy and it's well oxygenated. If an NST is negative, if an NST is not reassuring, and we normally have to actually do a further testing, which we call a biophysical profile, a BPP. This is where the doctors, the midwife, actually take an ultrasound, and or nurses that are certified. I used to work in the high-risk maternal fetal medicine clinic, specifically in the NST clinic. It's an extra certification to get your OB limited ultrasound certification. So as an NST nurse, I also did this with patients in the past. So basically, we're doing a biophysical profile. We're taking an ultrasound, we're scanning that baby, and we're assessing different parameters to see if the baby is actually hypoxic. If the baby is hypoxic, that will definitely require us to deliver this baby. So what we're looking at is the body movements, the fetal tone, the fetal breathing, the measurement of the amniotic fluid index, your non-stress tests. So each of these 5 categories are given 2 points with a total of 10 points. So 8 to 10 is normal. If we have a score of 6 or below, we are definitely concerned that there is something going on in utero with this fetus, and then we may actually have to potentially induce this baby, or induce the mom to have this baby early, and or if it's that critical, we may actually have to do an emergency C-section. So a BPP is also important to diagnose the well-being of the actual fetus. All right, so the next couple slides is just an FYI. You don't have to know this, just recognize it because you might see it in the documentation and the medical charts as you're working with your nurses on labor and delivery and or post antepartum. So these are just FYI. You will not be tested on this material based on the categories, but just be aware that you might hear this on the unit. And also the oxytocin challenge test. So this is not done very frequently. It's still, depending on where you work and where you're at. We do have some providers that are obviously old school, and they may put in an order for an oxytocin challenge test. So basically, this is a form of fetal monitoring. What we do is we actually induce labor. We actually titrate and we start an IV, we give oxytocin, and do like a practice trial test, a challenge test, to see how that fetus will do based on the contraction pattern. So uterine contractions may lower the actual fetal oxygenation supply, which causes decrease in the blood circulation because of the interference with the placenta flow. And so these are the babies that if there is a concern during this challenge test, if the baby is showing any signs of distress, we may have to actually start labor or potentially deliver this baby via C-section. So just an FYI, something to know. The other thing is when the nurse's documentation, based on the NICHD categories, they assign categories for communication. Um, Depending on where you work, most hospitals do have physicians in-house or a hospitalist. However, there are some community hospitals where the physicians are at home and they get to stay home until there's a need to actually have them come to the hospital and or deliver a baby. So when it comes to communication, the nurses often use category as a way of communication. So category 1 tracing means that the baby is strongly is doing great, right? It's perfect. It's healthy. We have a normal baseline. We have a normal heart rate. There's variability. There's accelerations. There's early decelerations, and no decelerations, late decelerations, or variable deceleration. So that's considered a category 1 tracing. Category 2 tracing is basically a tracing that requires intervention, specifically to variable decelerations and late decelerations. And category 3 means, as you can see here, red, that we have an emergency situation. There's a compromise to that fetus. It's predictive of a abnormal acid-base pH balance, which means that the baby, something's happening in utero that may actually compromise this baby in the future. So again, if the baby's having recurrent late decelerations, variable decelerations, bradycardic decelerations, prolonged decelerations, sinusoidal patterns, anything that is abnormal that continues and does not respond to nursing interventions, these types of strips will be considered a category 3 tracing. So we definitely want to call the doctors, get them in-house, let's deliver this baby as soon as possible. So you may see this on the unit as we're documenting our fetal tracing. The nurse's assessment, they have to document their overall assessment as to category 1, 2, or 3. So again, this is just an FYI. And then you may also see what wireless electronic fetal monitoring on the units. We call this the Novi or the Monica. What's nice about this is that there's no actual Toco or Sono, and there's no actual cord connected to a machine. Everything is wireless. These are usually they're very, very expensive. There's usually just a few of these on the floor. We normally keep these for patients that are prolonged inductions and or potentially a patient that has extra adipose tissue because of the thick layers of tracing. It's hard to trace a baby if the mom has a lot of adipose tissue. So using a wireless monitor such as this does, for the most part, do a really good job capturing that fetal heart rate. All right, I think